Okay, in the second part, I'm going to take a look at Chapter 5 in our SAMHMSA book, which hopefully you've downloaded or taken a look at. I also included the PowerPoint, which I would normally show you in class, though I don't give it to you. But since we're in an online situation, I've given it to you as well. So it'll probably seem like I'm reading to you, which I apologize for, but, well, I kind of am. Okay. All right, so when we take a look at SAMHMSA, let me put it up there, Chapter 5. All right, we're going to take a look at, given the many other special needs that we're confronting, it's apparent that there's no way we're going to be an expert in everything, okay? So this is why this particular chapter talks about special populations and special needs, because there's the general case management concepts we've talked about and treatment approaches, but then there's also the idea that people also need individualized care. So the case manager serving special needs clients should make every effort to be competent in addressing the special circumstances that affects these clients, and then understand that not only do they have those special circumstances, but they also have their own range of reactions to those circumstances, which is why, like, not every African American client is the same as another African American client, right? Not every Native American client is exactly the same as another Native American client, right? So we have to understand not only whatever their range of issue is, that is their cultural issue, but how have they been affected, and remain aware of our own limitations and our own limitations of experience and expertise. Okay, evaluate our own personal beliefs and biases about whatever the special need is, whether it's a developmental disability, or it's a mental health issue, or it's criminal justice or homelessness, right? What are my biases about that, if I'm honest with myself? And then maintain an open attitude towards seeking any kind of resource we can, because remember, from the perspective of a case manager, I'm really reaching out. I'm taking a look at who can I get to be part of this healing process for this client, and I need to know where I can find those people. So they say there's 5 elements associated with being culturally competent. 1, you need to value diversity to start with, okay? You need to believe that there's value in the fact that we're different, and there is. Yes, it can create misunderstandings, it can make things harder. Well, I acknowledge sometimes it's been a pain in the ass where I've had to try to find a special resource for somebody when I already have 14 things I need to do. I will totally cop to that. At the same time, when I breathe a minute, I say to myself, what's my primary directive here? I want everyone to be able to get recovery. That's what this person needs. I need to get over myself. And I do. Okay? Making a cultural self-assessment. What do I know about where I come from? Right? Who are my peeps? What are the traditions and values that are part of the way I'm wired? You know, I would say one of the 2 biggest influences in the way I think are, 1, coming from a military family. I would say that cultural thing is huge in terms of the way I see the world, the way I feel about work, the way I feel about stability. I mean, it's enormous. The military background in my family is enormous influence for me. Okay, I was also raised my family was raised Southern Baptist, and so there's that fundamentalist background somewhere that I don't practice at this point, but I certainly have that influence in my value system at some level. Okay. Which is both a benefit and also can sometimes create guilt. Okay, and I'm from the South. My parents are Southern, and so there's a certain amount of Southern rebellion and Southern value and rebellion that I bring to the table. So those are 3 just things right off the top of my head that I have to recognize about me, and how I respond to situations, and neither bad nor good. Okay, but sometimes those things will interact with a client's things, and then we might have a little bit of difficulty. Okay, understand the dynamics of when cultures interact. So yeah, I've got my own value system, my own background, you know, in the military, duty, honor, service. Those are all way more important than how you feel about it. So how I feel about shit, sometimes I ignore, and that's not wise. That's why recovery is helpful, right? Because in the military, you can just go drink. No, you need to be able to acknowledge how you feel about it. But if I'm not taking good care of myself and I'm martyring myself in my duty, honor, and service, and I see another person taking care of themselves, I can get pretty church lady and judgy. Like, I wish I had the time to do that. Okay. That's my issue. My lack of self-care is what I need to be paying attention to when I get all judgy about somebody who's practicing self-care. Okay? I wish I was in the same room with you, because we could have a lot of fun making examples of that. Anyway, incorporating cultural knowledge. So I need to be able to build in, what did I know about this? What have I learned about this? Who do I know from this who has the same background as the client? And then adopting whatever practices I need to accommodate their individualized needs. So according to Rogers, what does that mean? I need to have some cultural competence, which means I have to have the capacity for self-awareness. I have to have the ability to even notice and recognize the importance of differences. I have to have the ability to accept other people. And I would add to that, be curious. Be curious about other people. The ability to see clients as an individual, not just their culture, right? So yes, this person is, from Iran, or they're Iranian, but does that mean that they, are like every single Iranian on the planet? No. Okay, they also have their own particular family, their own particular issues. What is my willingness to advocate on behalf of my client? Because as a case manager, I'm going to need to do that. And then I need to understand that maybe their culture is one of the reasons they're responding in treatment the way they're responding. It's crucial for the case manager to be aware what may inhibit the minority's participation in the continuum. For example, and they give this wonderful example of accepting your powerlessness. It's a central tenet we have in the 12-step program. But man, if I already come from a background where I feel racially profiled, I feel like I've been disadvantaged, I feel like I've already gotten the short end of the stick, and you tell me, oh, I need to accept I'm powerless, I might have a problem with that. Okay? That's why a lot of feminists don't believe in the 12 steps, or feminists won't participate in our program, because they're like, that's bullshit. I'm working to not be powerless. That's a misunderstanding of powerlessness. Okay? We're saying I'm powerless over alcohol, and that is it. That is it. And in fact, when I remove alcohol, I am empowered. I am empowered to take control of my life. And I'm expected to do the footwork and do my life. Okay? So it's not that, oh, I'm powerless. I got no responsibility. No, I got all the responsibility. Okay? And I remove the one thing that's blocking my ability to assert myself, and I pull that sucker out, I'm fully empowered to do my life, and I'm expected to. Right? What do we say? It's not my fault I have this illness, but it is my responsibility to address it. Okay. The case manager needs to be sensitive to cultural differences, identify recovery resources, and so recognizing that it might help this person to maybe get an additional resource. It's like their clergy, their elder, go to celebrating recovery because they need a biblical-based approach. Fine. Others might use a cultural approach and want to go to a Native American specific program that builds in their some of their indigenous beliefs and systems. So then your book goes on to talk about specific areas like areas of HIV and AIDS. And so one of the things that can be more challenging working with HIV and AIDS, or particularly when this first happened in the 80s, and I started working in the field in the early 90s, a lot of fear of contracting HIV. A lot of this stuff has been wiped out with universal precautions. It's now standard that anytime there's a fluid, we all wear gloves and we wear booties, and yeah, it's very standard now, okay, that we wear protection, because the truth is, it's not just HIV, it's Hep C, it's God knows what, because, we're not taking care of ourselves when we're out there. So people bring in a variety of potential fluid-based transmission illnesses. And so in general, we just don't touch clients, we don't share forks and spoons. We don't, we wear gloves when we have to deal with things that are, bloody or whatever, clean up a vomit, right? We don't just do that. We take care of ourselves. And is there a stigma of having both drug abuse and HIV? Sure, there really was. There probably still is. People still do feel a little afraid of it, even though when I first came in, you automatically died. It's not true anymore. People live. They live 20 years, 30 years. It's amazing to me. It's amazing to me in the last 30 years, because it was an absolute death sentence when I came in. We're just starting to have medications that would help with, prolong your life a little, but you were going to die. And so people were terrified, and the client would be terrified. And in fact, it still is part of our confidentiality, right? That we can't tell anybody a client has HIV. Mostly, not even necessarily biased now from the staff, but from the insurance companies. So it's still a protected status. And HIV was progressive. It is debilitating. There's a lot of different meds you need to take. You have to take them as prescribed. You have to take them on time. Less so now. It was a much bigger cocktail before. We're getting more sophisticated, I would say. However, they're still expensive. Okay, HIV meds are expensive. People need health care to afford to treat both their Hep C and their HIV. So if somebody comes in, they get tested. We need to make sure they get on some sort of medical plan if they don't have one, because they're going to have to manage this, and it's chronic. They're going to manage it for a lifetime. So, and the meds are not cheap. All right. And we used to have, again, hopelessness, because, again, you automatically died. People would say, what the hell, I'm going to die anyway. So then the challenge was quality of life prior to dying. So when I first came in, that was the issue, right? You could have quality of life in the few years you got left, or basically you F it and you go use them because you're going to die anyway. That was the dilemma back then. Now, again, people live much, much longer. So there's not the right away thing that we used to have. One person should assume primary case management responsibility for HIV, but you're probably going to need a team. It's true, particularly back when people were dying so all the time. But even now, you're going to have your medical professionals. One of the things about HIV can be depression, anxiety. So there might be a psychiatrist, a medical person you need to include, as well as into your treatment planning for how this person's going to manage going forward. Okay. Then they talk in your book about clients with mental illness. Almost 40% of people with alcohol disorder meet the criteria for psychiatric disorder, greater than that for drug disorders. Coexisting disorder is, in general, just higher for people in treatment, about 80% in some studies. And I think our experience teaches us that, right? It's not 50%. I know SAMHMSA says 50%, but if you look at who's in the treatment facility, it's higher. It's absolutely higher. So SAMHMSA is saying, looking at across the country, right, in the United States. But who's actually in treatment is often people who have additional issues. Because they can't be functional alcoholics, if that makes sense. If you could be a functional alcoholic or drug addict, you're probably not in treatment. So we're getting people that have a higher problem with functionality, which means more criminality, more mental health, more homelessness. That's why our numbers are higher. So given those high comorbidity rates, we need to be prepared to address dual diagnosis services. And they talk about sequential, parallel, or integrated model. In the integrated model, both disorders are dealt with in the same time. So that means we're going to have to transition from residential care to the community, meaning we're going to have to hook them up with mental health, starting with residential right away, get them connected with those resources that are going to follow them post-discharge. Many of the special case management issues with mental illness has to do with their prescription medications and how they affect their bodies. You can, when you're first getting stabilized with your mental health medications, you can look loaded. Okay, you can look like you're over-sedated. You sleep more. And so this can be hard because they can look like they're loaded and really they're on too much Seroquel. So you need to pay attention to the dosage. Sometimes if they were on meds before, the psychiatrist will make the mistake of putting them on the exact same dosage that they were taking before, but before they were also using meth or using alcohol or using weed. And so now that they're clean and sober, that same dosage is too much, which is why they're sleepy or groggy or having difficulty functioning. Some treatment programs actually will precipitate a client's relapse by taking away their medication. We don't do that here in Santa Clara County, but there are still programs out there that do, out in the wild, particularly private programs that will say, can't take nothing, never. We certainly can still hear that in the 12-step program. Drug is a drug. That is absolutely not true, and it is malpractice if we say that to a client. You don't need your bipolar medicine. You just need meetings. It's horrific. Okay, so to manage client symptoms and behaviors, we need to anticipate problems, reinforce medical management. We need to know the knowledge about their medication, possible side effects. Every treatment program has one of those pill books, you know. It used to be called the pill book. And you just can look up the medication. You can look it up online and see what you're seeing. Okay. Aftercare tends to be long-term with mental illness because when people are feeling better, they just stop taking their medication. Okay, we see this all the time. And what happens? They stop taking their medication, the mental health symptoms come back, they start drinking and using. Okay? So we do have programs like Double Jeopardy, Dual Recovery Anonymous, programs that allow people to talk about both their mental health and health medications as well as their substance use recovery. Okay, because again, most treatment programs, or I'm sorry, most 12-step groups, you don't talk about your mental health meds from the podium. Not a good idea. Homeless. The need for case management with this population is obvious. They need suitable short and long-term housing, lots of mental disorders, significant health problems as a result of homelessness lifestyle, tuberculosis, HIV, Hep C, unemployment. So we're looking at people who have a lot of tangible needs right from the gate. So where does the client want to start? What's most pressing for them? Ironically, it might not be getting stable housing. That's what we want for them. That may not be their issue, by the way. Okay, that in fact, it might, their book says at the top 54 of their list, they actually prefer the street to the shelter because they're familiar, because they have a support system to watch over them out there. They've created a little network. Okay, so some clients may say, yeah, no, I'm not going to go stay in the shelter. Hell no. No, I feel safer out there. I've got my own little community. So our rapport building skills are going to be critical to get through the defensive behaviors and protective attitudes people need to be able to live on the streets, okay? They need those defenses. Looking tough, acting with bravado, wariness. I would say look kind of feral. Sometimes a hard exterior, not a lot of social grace, not a lot of please and thank you. Okay, so they're hard to engage sometimes. Okay, they're hard to engage, and these behaviors can interfere in them being successful, and you need to not take them personally. Okay. One solution is engaging homeless clients through the use of peer case managers. I'm a huge fan. Love peers, particularly with homelessness. People who have come from homelessness get it. They get it. They get it. They're better in shelter care facilities. In fact, I think they can be more effective because their capacity to tolerate obnoxious behavior is higher because they don't take it personally. They've been there. They've done that. Every homeless program needs peers who are doing it, okay, who get why it's hard. Because for a lot of people, getting a stable housing, it seems like a no-brainer. Well, it's hard. It's hard to maintain. The delivery of social service is complicated because homeless clients are turned out from the shelter from usually 9 a.m. till 4 p.m. And so often they're hanging out with people who aren't clean, aren't sober, places, you know. So we may need to create things like a day room, right? That's why we've got the mental health people have Zephyr and other drop-in places where people can go in and get a snack, might be able to watch TV. So with these guys, we might need to do more mobile case management. We need to go out to where they are, out to the jungle, out to where they're living on the freeway side. We need to go to them because that's where they are. Okay, not so good with time management. Okay, then they talk about women with substance use problems. Case finding is especially important here because There seems to be a different path for a lot of women to treatment. We're often referred by other service providers, and so there's often a lot of social service involvement with our women clients that may or may not be there with our men, particularly if they've got children. They may have numerous child-related services. They've been maybe victims of domestic violence, so been at the battered shelter. Other women appear at mental health centers or women's health centers. So there's a lot of correlating physical, mental illness and trauma that could be the pathway into substance use treatment. Once identified, what's happening is they've been referred to DV or been referred to maybe parenting, but their substance abuse is interfering with their ability to complete those programs. Often judges will be harsher toward women because they believe moms should know better. So a woman's addiction may have progressed significantly before they're ever identified. A lot of people have denial about women using. It's not that bad. There's systemic barriers like childcare for women to seek treatment. There's sexual abuse, emotional dependency, transportation. It can be huge for women. Okay, it's hard to take the bus with a stroller and a toddler, and it's just hard. It's just hard. So women's involvement with community resources often puts us in a position to advocate for them, which means in addition to treatment, we need to look at acquisition of other resources that help her be effective on her own. Now, she does need to fulfill her legal obligations, okay? And we need to report child abuse and neglect, no matter if our heart may go out to her, but the reality is she can't leave her kid with the dealer while she goes to work, okay? There's some things that have to be put in place, that sometimes decision-making that's dangerous for the child. I've had clients do that. They didn't want to leave their kid alone, so they take their client to buy the drugs. Not their child in a stroller. And I had one woman, she felt it was safer to leave her baby or her toddler in the stroller outside of the dealer's apartment because she felt that was a better choice than taking him into the dealer's apartment because there was drugs there. Well, honey, you just left him alone out in the hallway in a sketchy-ass hotel. So those kind of decisions that people make when they're loaded, and they're still trying to do their best maternally, but their thinking isn't clear. And so sometimes, they might need to go to House on the Hill, a program for women and children, or House of Grace, because they can't parent effectively until they've got some stability with both their emotional and mental health. All right, then they talk about adolescent substance abusers, okay? Again, we're going to do a lot more family work here. You have to have an understanding of developmental issues and brain development for adolescents and kids. You have to be able to get along with kids and like them and not mind when they roll their eyes and they're kind of a pain. Talk to you like you're a half-wit. So you need to do a lot of case management with poverty, child neglect, maybe parental substance abuse. They're not the first addict in the family, okay? Acquiring the entire family is your caseload with a teenager, okay, or a kid. So you need to take a look at that. You're not going to be able to see the kid, a minor, without including everybody. So your case management model in your book describes a 3-phase approach, providing services during pre-treatment and screening, how services are provided in residential treatment, and then how you provide services in continuing care. Family engagement in transition and aftercare is paramount, particularly for adolescent juvenile justice client, because you have to start that transition rule setting and planning and structure before they ever return home. Finally, we've got, I don't know if this is final, but next we've got clients in the criminal justice settings. Again, this can also be very complex because you have 2 different systems with 2 different focuses and goals and philosophies. The criminal justice system is not particularly interested in rehab. Honestly, they're more focused on public safety. That's kind of their job. They're about punishment, sanctions, where we care about public safety, but our primary mission is the individual. So really have 2 different things here. And they're not mutually exclusive. In fact, we can integrate the 2 systems and have a really powerful outcome. But recognize, depending on the criminal justice worker you're dealing with, they may definitely err on the side of safety and public safety versus the individual. Okay? So because participation in substance abuse treatment and other social services is mandated, we do get to keep them longer, which is why we actually have better percentages for mandated clients, all right? Because we can hold them. They can't just walk because, you know, it's been 2 weeks and they feel better, like a self-referred person. So integrating the systems requires some effort. We have to establish and maintain therapeutic relationship with clients while still managing the sanctions and obligations of the criminal justice system. So clients can be a little sketchy about us, like, well, how much are we going to be talking about what's going on? What are the confidentiality issues here? Case management with offender populations can be implemented at any point. We see a lot of people as part of their reentry system. Now that we've had the reentry program for many years now, it's really effective. It's really helping people get connected. It helps them find housing. It helps them to get job-seeking connections. So it may be that we're going to be working with a variety of people over the recovery, or I'm sorry, yeah, the what did I call it? Recovery. Well, reentry. Sorry, I lost the word. Brain fart. Reentry center. People from faith-based, things like that. Goodwill, in addition to what we're doing. Okay, the case manager should address the needs of clients released from institutions in terms of importance, which is stability, stability, stability. We need stability of housing, support, okay, aftercare, anything that supports them in their self-efficacy, the belief that they can actually do this thing, okay? Secondly, we need to provide for skills. People in lengthy sentences are going to need a lot of support with job search, hanging out with non-offenders. They may not know any. A lot of our people, their entire family is full of offenders. They don't have any non-offender support. Okay? They don't know what that looks like. And they sure don't know how to problem solve other than in the here and now, you know, right this second. But their planning skills have probably not been utilized. Certainly if they've been using, and they were using while incarcerated. So you're not looking at people that are 35 or 45. You're looking at people who are 16 or 22. Third, you need to help find training in short and long-term goals for them. So again, they're going to have to repeatedly begin to take on responsibility for their lives, and a lot of them have not been able to take responsibility for their lives, even if they wanted to, in a long time. They've been in the system a long time. So while goal setting is important to any client group, it's particularly important to these clients because they've had things provided for them, everything from their underwear to their toothbrush. So we're going to have to help them figure out how they're going to get what they need when they get back out into the environment. Simple things, clothing. How are they going to take care of themselves? Okay, how are they going to feed themselves? We're looking at, they do say one, helpful development. Recent research has convincingly documented the success of compulsory and coerced treatment. This is what I've been telling you, that actually all the research shows that mandated clients do better. Okay? Structured case management between criminal justice system has facilitated lots of the same goals through both systems. We both do drug testing. We've both been able to reduce drug use and criminal behavior. I mean, one of the ways that we measure success is not recidivizing, right? That they don't go back to jail. Well, that's the same way criminal justice measures success. They don't come back. Providing systems of graduated interventions, offering treatment in lieu of punishment. You know, we do have, you can do residential in lieu of time served. We do have that here. We've got a lot of drug courts here, mental health drug court, juvenile drug court, domestic violence drug court. We got some drug court here. And so we can use the courts to influence people's behavior. Oh, here's the other one I was thinking of. Okay, clients with physical disabilities. Chemical dependency is a coexisting problem with many people with physical disabilities. 15 to 30% of all people with disabilities abuse substances, which is more than twice the rate of the population. Remember, you know, the average population, it's about 10 to 12%. So when you're looking at 15 to 30%, that's a lot of people using. Okay, they're highest among people with traumatic brain injury, spinal cord injury, mental illness, and learning disabilities. Okay. The case manager delivering services to this population needs to know and understand these conditions, as well as blindness, deafness, chronic disease. Other suggested areas of knowledge are things like The etiology and course of physical disability. Obviously, you're not going to know the history of every physical disability on the planet. But if you've got a client who comes in with a spinal cord injury, you can ask them where on their spine the injury took place, where on the spinal cord, and you can just research it. Say, okay, what are the symptoms for people with this particular injury, so you can understand their injury a little better. You don't need to be an expert, but you can get a pretty decent working knowledge of what this person might be up against. You could take a look at treatment options, both group and individual. You know, do a little research. Who has already treated this group successfully, and how do they do it? You need to learn the difference between appropriate disability accommodation and enabling handicapped behavior. Okay, a lot of us, our instinct is to do for, particularly for codependent. We do too much. We need to let people struggle, even with a handicap. Okay, even with a disability. Sometimes people with a disability, they can do it, and they'll say that, I can do it, but they need a little more time, right? And we get impatient. We got other clients to see. We got stuff to do, all right? So this idea of you're going to have to slow it way down with somebody with a disability sometimes. You're just going to have to give it more time. It's going to take more time, okay? That with cognitive processing in particular, you're going to be repeating yourself. Everything is going to be slower. Okay, and then you got to take a look at how they accept their disability themselves. How angry are they about the disability? People are grieving the loss of their former selves. Grieving, angry. This is bullshit. Why didn't I just die? I mean, they are in pain sometimes. It's hard to hear. Okay, but you need to hear it. You need to let them say it. You need to be able to validate. That sounds like you have an incredibly hard decision to make. You're either going to stay crippled with your disability, or you're going to get into recovery with your disability. Disabilities is going to be the same. So your decision is how you want to identify. Do you want to identify as a person with recovery, or you want to identify as a person of limitations? Really, that's what you're going to have to do, because the illness is not changing. It's a hard one. Because many social service professionals still assume that people with disabilities are helpless or don't understand it. They aren't paying attention to what the clients are taking. They could be absolutely abusing the crap out of their opiates. Okay, they probably are. People just give them to them. Doctors just give it to them. We need to pay attention to their opiate abuse. Say, we'll just let them abuse it. No, people die. Okay, we need to be paying attention. And you know what they need? They need a decent pain management program. And there are programs around here that will work with pain management. So it's not that they don't need pain management, but giving them a crap of opiates all the time, which keeps them, checked out and not functioning even to the level to which they're able, not okay. Not okay. Assessment includes issues that are specific to physically disabled people. So looking at the relationship between the client's disability, substance use, and recovery potential. So people who had a significant substance use problem before becoming disabled, okay, they've got a chronic substance abuse illness, and then along the way they got injured, they were in a car accident, versus a person who had the disability before they ever picked up. Okay, so the person may over-identify with their disability because they've always been disabled, right? Or they may over-identify with their disability because it's completely changed their life, that they used to be able to walk, they used to be able to see, they used to be able to hear. So you kind of have to feel that out. Again, it's the identification. You're going to identify as a person, right, who's blind, and so crippled by your blindness, that's it. Don't expect anything from me, I'm blind. Or you can be a person in recovery who is blind. Because a person who is in recovery and who's blind has options, right? They have to decide, though. It's very personal to them. Others may have acquired a disability as a direct result of substance abuse, but without sober time for understanding the disability, they're not aware of their functional limitations. These are some people who, they got a head injury while using, and they were kept drinking right after they got head injury, so they don't know they don't see the connection between, they don't recognize how much their functioning's changed because they were using. I have a friend like this. In fact, he got his head injury falling off a ladder, drinking, and he drank like within a week of, started drinking heavy again after the head injury, And so, yeah, he doesn't even know how much of his issues are the alcohol and how much of it's the head injury. It's hard to know because he's a mess. We have to sober him up first. Not that he wants that. Okay, so the person in a wheelchair who must take medication for chronic pain may prompt resistance and recovery-oriented self-help groups. It's true. There are some recovery groups that would, again, they're going to fight taking medication for chronic pain. All right, there is somewhere around here, because somebody told me about it, a NA group for people with chronic pain. They need to have chronic pain support, okay? Pain meds need to be part of pain management, okay? It doesn't necessarily mean a substitute. They may still need to take opiates occasionally. They may need to do that. Okay. What else are they doing? Right? Are they swimming? Are they walking? Are they stretching? Are they doing meditation? Are they using things like my EM wave? What are they doing to manage their pain? In addition to some medication. All right? Some vocational problems require clients to be sober for some time before they can train them, and they don't consider opiates as sober time. Now, the other thing you can do with people sometimes, particularly opiate addicts, they can get off opiates and they could consider things like Marinol, which is which actually I'm a fan. It's the CBD version of marijuana. All it does is pain management. It's prescribed by a doctor, right? It's made in a laboratory, not down at the weed place, okay? Marinol, M-A-R-I-N-O-L. In fact, a lot of opiate users are using Marinol and CBD instead because it does manage their pain, but it also doesn't trigger their cravings. Okay? So looking for other things other than opiates. Okay? If nothing else will work, we'll have to do opiates. But yeah, let's take a look at some other pain management. And again, they may have to take something. Okay. Okay. So you may need to take it, what kind of vocational services they can use depending on the kinds of medication they're using and how impaired they are by their medication. Then we have gay, lesbian, transgendered, and bisexual clients. These cultures are often also associated with substance abuse, largely because initially the only place you could meet people for the most part was a bar. It's kind of where you hung out. Okay? So people, you take a look at people coming out, and depending on where they're coming out, their opportunities for socialization and connection are pretty limited. So, and how they feel about coming out may be hard for them. Substances make that transition a little easier. Sometimes where they find their partners is places where they're more likely to get Hep C or AIDS. So the prevalence of use coupled with homophobia can make it hard. Like, well, is the person hanging out at the bar to meet people, or are they hanging out at the bar because it's a bar? Challenge. Given the emotionally charged atmosphere that surrounds sexuality, case managers need to take a look at their own feelings and beliefs that they have about gay and lesbian and transgender people and their relationships, and you need to be aware of any transference you're bringing in, okay? The link between personal beliefs and interviewing skills is particularly important with these clients because they might be reluctant to discuss health problems or sexual practices connected to their drug use. And there are some, and we have to be able to create a place where they can talk about how they're using poppers or how they're using meth or how, that there may be some group sex going on or some polyamory going on when they're using that they feel shamed about, or they just don't feel comfortable because they're afraid you'll judge them. So you have to sort of create a place where, they can kind of say to you what's really happening for them. You need to know the context of their life. How do they talk about sex in their own community? Maybe they're practicing S&M. They're part of an S&M community. That's part, and they have been for years, and they use it safely, and they like using it. However, drugs and alcohol have become part of that. So I would say sexuality in general can be challenging. Okay? It's important to address the transgendered client by their identified gender and name. I put that in red. The client gets to decide their gender, and the client gets to assign their name. I know in criminal justice it doesn't work like that. I know in criminal justice you're called by your legal name. I understand that. but we're a treatment program, and we're allowed to do it differently than criminal justice. And if a client wants to be identified by a particular name, why not? Now, here's the exception. I don't let them go by their street name. Okay, so if their street name is Dopey, we're not calling them Dopey. We're going to call them Charles. All right? We don't call them by their gang name. But their gender name? You bet. You bet. Now, a case manager should know which 12-step meetings, clinics, and other resources are more accommodating and supportive of gay and lesbian communities, transgendered community. So you need to help them develop social opportunities, which will come through, in Silicon Valley, we have a great gay and lesbian recovery support here. They do really fabulous things like fundraisers, drag things occasionally. They'll have sing-along movie nights. They got all kinds of groovy stuff. So we really have a particularly active and fun gay and lesbian 12-step community here. So we're fortunate. We really are. Advocacy for gay clients includes helping them seek treatment for injuries, affections they may have picked up. Maybe they've picked up some STDs they need to take care of. Okay? And so we need to take them seriously. Okay, is that it? That is it. Alrighty. So we're finished for today with our lectures, and then you've got your quiz, and you've got some videos I'm including. Alrighty. Take care, guys.